last speaker for this session is going to be Ahmad Mourad. As Georgia had mentioned to you earlier this morning, the CFAR Developmental Corps tries to mobilize to issues arising, and so one opportunity we had to do that was issuing a special call for applications on Mpox. And so that'll be, so Ahmed was one of the recipients of this group, so he'll be presenting on those data today. Ahmed completed medical school at the American University of Beirut, followed by internal medicine residency here at Duke, and he's currently a senior clinical infectious disease fellow and also a research fellow at the Duke Clinical Research Institute. So please, thank you.
Thanks, everybody. I'm aware that I'm the speaker standing between you all and lunch, but we're going to make it. As Dr. Rees mentioned, this research was funded by CFAR, and we're grateful for the funds and able to do this project. So I'm going to go briefly, for the interest of time, just a quick background on Mpox, and then take you through how we built this project and share some of our results. So just really quick, so the Mpox virus, formerly known as monkeypox, is a zoonotic orthopox virus that prior to the outbreak in 2022 was mostly endemic to Central Africa with an animal reservoir, and then was transmitted to humans through the animal reservoir. But in May 2022, we started hearing of cases of human-to-human transmission in countries outside of the endemic region, and the pattern of transmission was thought to be through skin contact and bodily fluids. So the Mpox virus then causes an Mpox clinical syndrome, incubation period of usually 1 to 2 weeks after exposure, in which patients are asymptomatic, and then a prodrome of fever, nonspecific symptoms, and then usually followed by 2 to 4 weeks of the illness, which usually manifests, depending on the degree of immune suppression and, or immune compromise that patients have, as a painful rash. That's what we most commonly have been seeing in these patients. The rashes usually start as painful macules and then eventually progress to pustules. In patients with severe immune compromise, so patients with advanced HIV or AIDS, we have seen severe cases manifest with proctitis, and then proctitis severe enough to actually cause bowel obstruction requiring surgery. In terms of the epidemiology and trends that we've seen, so the first couple of thousand cases that were reported in July in the United States, we were mostly seeing this being transmitted among men who had sex with men, which was consistent with patterns internationally, mostly in Europe as well. And a lot of those patients had HIV, and a lot of those patients had at least another STI diagnosed in a year or other period of time preceding the acquisition of Mpox. And so taking all of that into account, it was pretty clear that Mpox was behaving like a sexually transmitted infection at that time. So here are some national trends from the CDC, and you'll see here below are trends of Mpox testing at Duke, and that kind of mirrors the wave that we had over the summer last year. In terms of prevention and management, there isn't much. We have a vaccine and antiviral therapy that were both developed initially for smallpox but repurposed for Mpox and deployed in June of 2022. The antiviral therapy we reserved clinically for patients who had more severe disease, like severe proctitis. But otherwise, in patients with mild or moderate disease just presenting with rash, most of the time we were just doing supportive care, so just giving them anti-inflammatory therapy and pain management to get them through their illness. All right, so to talk about our project. So again, just you see that curve of the trends. We were seeing a lot of these patients in the summer of 2022. We were seeing them in clinic. We were also seeing them in the hospital admitted with severe Mpox. And so a lot of clinical questions came up during this time. And Jason Stout, who is currently cycling through Portugal, thought that the CFAR would be a great opportunity for us to put those questions in a grant and try to answer some interesting questions that we had when seeing these patients. So we got our faculty together, mostly people who see these patients and have done a lot of work in this space before, to kind of come up with a strategy moving forward. So we had two main clinical questions that we wanted to answer. One is, based on the trends that we were seeing in patients nationally and internationally, it seemed like a lot of patients were being diagnosed with concurrent STIs at the same time of their Mpox diagnosis or preceding their Mpox diagnosis. And so it's important to know if whether patients are being appropriately concurrently tested for other STIs when they present for Mpox, since the risk factors for acquiring other STIs are essentially the same as those for Mpox. The other question was, who was getting vaccinated? Are the appropriate people getting vaccinated? And another question within that, too, is we know from other vaccination efforts most recently and most notably with COVID, there is some disparity in vaccine deployment and who actually gets vaccinated. Whether that be racial and ethnic minorities or socioeconomic disparities, as well as disparities in risk factors. Like, are the people who are at highest risk and who would benefit more from the vaccine the ones getting vaccinated, or is it the people who are at lowest risk of acquiring the disease the ones being vaccinated disproportionately? And then the third aim that we wanted to do, which isn't really a question, but we thought this would be a really good opportunity to build a biorepository of specimens from these patients, both who had Mpox as well as got vaccinated for Mpox, for people smarter than us down the line to use for some exciting research. And then another thing that was a big component and maybe the most exciting component of our project was how we were going to do this. And so our infectious disease fellowship, just for some context, is a 3-year fellowship. The first year is very heavy clinically, and then the second and third years are traditionally when fellows conduct their research. And so first-year fellows going into their second and third research years may not have a lot of research experience, may not have built those skills or acquired those skills in residency or early in fellowship that they need to really hit the ground running when they get to their second and third years with research. So we thought this would be a fantastic opportunity to incorporate the first-year fellows into a large project like this from the get-go, have them involved with building a project from A to Z, how grants get written, how data gets collected, how it's analyzed, how posters and abstracts are put together, and how manuscripts are written. And so we thought that this would be a really novel training and educational mechanism for the first-year fellows, and that was one of the most exciting parts about this. And then for the senior fellows like myself, although in our second and third year of fellowship, we do get a lot of experience in conducting research, we maybe don't get a lot of experience with managing research teams. And so we also thought this would be a great opportunity for senior fellows like myself and like Nassim to take charge of a team, to work with a team, to manage a team on a project like this. And that was one thing that we were really excited to do with this project. So this is our trainee team, the first-year fellows at top and senior fellows at the bottom. And so when we decided that once we got notice of award and started working on implementation of the project, we wanted the fellows to be really involved with the implementation, but we also wanted to respect their clinical time. And so we came up with a good balance where we would have 1-hour working meetings once a week, where faculty, junior and senior fellows met. We had designated learning topics. Sometimes we had readings ahead of time, but most of the time they were actually working meetings where we were going through things all together. And that involved things like pulling data from Deduce, how to run an analysis in R, and things like that. Very hands-on, practical research methodology and implementation. And that's what we did for the months after we got official notice of award until we were able to produce results from our research. So I'm going to go briefly through the aims and results. So for the first clinical question regarding concurrent STI testing, our big aim here was to evaluate whether evaluate the patterns of comprehensive STI testing that was done concurrently in patients presenting for Mpox. And our hypothesis was that concurrent testing will be low, and patients who are presenting to higher clinical volume settings may be less likely to receive comprehensive testing. And the reason that we had that specific question is that a lot of the patients that we were seeing in clinic were patients that were diagnosed with Mpox and then referred to infectious disease after having the diagnosis made at an urgent care or emergency room first. We pulled the data from Deduced and we looked at concurrent testing results, both the results as well as the anatomic sites that were tested. So overall, we found 225 patients tested for Mpox over this period. 23% of them tested positive. 70% were male, which is consistent with national and international trends. Actually, maybe nationally and internationally, there was a higher proportion of males. And then 42% were Black. And I wanted to just point out a couple of things here. We have a couple of tables to go through, but I'm not going to go through them in detail. But among the patients who were tested for Mpox and were negative, we see a majority of them were Caucasian or white. And then among those who were tested and were positive, a large majority were Black or African American. And this did fit a pattern with national trends as well. I put this table up here just to show how poorly we document, or how poorly the EMR documents these variables. You know, these are important variables to know, especially when studying a disease like a sexually transmitted infection. And you can see most of, over 80% of this data is unusable. And that's something that we really need to work on improving in the EMR. We didn't do individual chart reviews, so this was just based on fields that are filled in the EMR. And then among all the patients that were tested, around 15% were known to have HIV. And among everybody who were tested, only about 6% were tested for concurrent STIs. So 40% of patients who were presenting for Mpox testing were not tested for a concurrent STI. And among those that were tested, again, only 60%, 15% of those tested positive for a concurrent STI other than Mpox. So there is clearly a gap here that we're not testing enough patients and we're missing concurrent STIs at the time of Mpox presentation. Another interesting thing that we also wanted to look at was how comprehensive the STI testing was. So we know from historical data that extragenital gonorrhea and chlamydia are underdiagnosed, and you can see here that very few people got rectal and pharyngeal testing, and the majority of patients got urine testing. And that's probably because they're presenting to a clinical setting where it's probably just very convenient to order the urine and maybe not very convenient to order the rectal and pharyngeal swabs. And then in terms of our other question about whether the degree of testing was different depending on the clinical setting in which patients presented, we actually didn't see much of a statistical difference, except actually the emergency department was more likely to test patients for incident HIV. So that was good to see. So in summary, concurrent STI testing was not consistently or comprehensively performed in these patients. Among those tested, around 15% were diagnosed with an STI, but again, there's probably a big gap there that we're missing. And then testing did not vary between healthcare settings. I'll go quickly through the vaccination disparities aim too. So here we wanted to describe the characteristics of patients who were vaccinated and then examine correlates for uptake of vaccine. And our hypothesis was that patients from racial and ethnic minorities and lower socioeconomic status would be less likely to get vaccinated, and then groups at highest risk will be disproportionately under-vaccinated. So to do this, we created 3 different cohorts using Deduce. We pulled our clinic patients with HIV, so those are patients that are followed at Duke with HIV. We pulled patients who are on PrEP, and then patients who are vaccinated for Mpox at any Duke health setting. And so that last group, the patients who were vaccinated, overlaps with those first 2 groups, if that makes sense. So a total of 807 individuals were vaccinated. 224 out of the 2,000 clinic patients were vaccinated. 50 out of the 226 patients who were on PrEP were vaccinated. So you'd notice that 224 and 50 don't add up to 807. So the majority of patients that were getting vaccinated were actually not our clinic patients and not patients on PrEP. For our analysis here, our primary endpoint was receiving at least 1 dose of the vaccine, and then we had predictors for vaccination. Just to touch on a couple of things, we used an STI diagnosis within the past year as a surrogate for being at higher risk for acquiring Mpox. And then we also looked at prior COVID or influenza vaccination as a surrogate for vaccine acceptance or hesitancy, with the thinking that if people were getting their COVID shots and their flu shots, they were more likely to be open to getting another vaccine, like an Mpox vaccine. So among the patients living with HIV in our cohort here, you see 99 or almost 100% of those who were vaccinated were male. So that is, the highest demographic group at risk. Majority were non-Hispanic, however. and around 50% were Black or African American, and a really big majority of them were patients with private insurance. And then in terms of risk, we had patients who had an STI in the year preceding or during the outbreak. 43% of those were vaccinated. And then an STI in the year preceding the outbreak, around 30% were vaccinated. So patients on PrEP, similar trends, but interestingly, more uninsured patients in this group. And actually, in this group, we had a larger representation of Caucasian and white patients. And then among all patients vaccinated, so this includes the patients in the first two cohorts, majority were Caucasian white, majority were non-Hispanic, majority had private insurance, and again, this other group that didn't fall either into HIV positive or PrEP were the majority of patients who were getting vaccinated. This might be due to the pop-up vaccine clinic that we had where people could come in and get vaccinated. This is a really interesting visual here. So this blue line represents the proportion of our clinic patients that are represented in each one of these races. This light blue bar is the proportion of patients who are vaccinated for Mpox. This orange dot is the proportion of our clinic patients who actually got Mpox, and then this yellow dot is the proportion of patients who got Mpox in North Carolina. So you can clearly see here that there's a racial disparity in who's getting vaccinated and who's at risk and who's acquiring Mpox. And then this is just a graph looking at the missed opportunity to vaccinate patients who really need to be vaccinated. So using a vaccination goal of 100%, we're missing almost 60% of high-risk patients who are white, and almost 80% of high-risk patients who are Black not getting vaccinated. So in terms of our analysis and odds of Mpox vaccination among patients living with HIV specifically, white patients were more likely had higher odds of vaccination compared to Black patients. Patients who had private insurance had a higher odds of vaccination compared to patients with Medicaid. But then it was interesting to see that actually patients with recent STI diagnoses and had received prior vaccines had higher odds of actually getting vaccinated. I'll just skip through these. Okay. So in summary, the rates of Mpox vaccination were low amongst the high-risk groups in our cohorts. White patients and patients with private insurance were more likely to get vaccinated, and then prior vaccine uptake was associated with Mpox vaccine uptake as well, so that was good. And then in terms of the education, so those are our results. In terms of the educational experience and the output, so again, we wanted this to really be a trainee-centered experience. And so through this, we were able to send 2 of our trainees to Croy to present 2 abstracts there. It was a great experience for them. And then we were able to get our senior fellows to actually author 2 manuscripts that were recently accepted at Open Forum Infectious Disease, discussing these 2 topics. And so from time of inception to having everybody trained in the research methods, doing the implementation, getting 2 posters and 2 manuscripts published is less than a year. That was just a really great testament to our team. So I want to thank the CFAR. I really want to thank Jason. This was really his brainchild. None of this would have been possible without him. And thank the rest of our team as well. Thank you.
Well, that was really fantastic. Any questions? Oh, I think I see Sadie.
Hey, great presentation. I was curious if you were going to avoid a deficit sort of frame for this, so not saying there's anything wrong with the people who did not get vaccinated, how would you explain the disparity?
Yeah, that's a really great question. That's something that I think we're still trying to learn from other healthcare disparities as well. Why are patients disproportionately receiving care in the patients who need it? And that's something that we actually dedicated several sessions to in our fellow education, I guess, quasi-curriculum that we made, was something called the inverse care law, and trying to really understand why the patients who are the patients who are less likely to acquire or actually less likely to have worse outcomes are the ones who are seeking more healthcare. And that's something that I still don't think we really understand very well. It's from what we can see, and one of the slides that that I skipped over was looking at things like social vulnerability index as a marker for socioeconomic status or insurance, and we really, in terms of social vulnerability index, really didn't find a difference in terms of time to getting vaccinated. We did find a difference in terms of insurance, so that might be something that causes deterrence to receiving care. But yeah, still something we're trying to understand.
Okay, maybe one quick question last.
Wonderful talk, Ahmad. I think the timing of and the access to the CFAR funding was absolutely essential in being able to do this interesting and important research and move forward. But that timeline that you put up showed that delay of about 2 months between when funding was accepted and when the IRB was approved. Has there been an opportunity to provide institutional feedback that we've got some support, for example, through CFAR for moving forward during an outbreak or pandemic, but what's the institutional support to help us move forward with our research without these types of delays?
Yeah, that's great. I think the efficiency of outbreak research is lacking. I think institutionally there needs to be more of a push to making sure that outbreak research happens efficiently and happens when the outbreak is actually still occurring. This delay actually. So as part of our third aim, which I didn't get into, was collecting specimens from patients who were infected or vaccinated, and we actually had a timeline of when we wanted to collect these specimens. And because of this 2-month delay, people actually timed out, so we lost patients that we could have collected specimens from. And yeah, I think that from our end, we still haven't taken this feedback to the institution, but I think that building the efficiency of outbreak research is something necessary. Things that can be done is streamlined IRBs, integrating research into the clinic when we're seeing these patients, and integrating research into the EMR itself, I think, are steps that we can take to improve efficiency.
Okay, great. Thanks very much.
Thank you.